Testing. Shall we try again?
Oh, yeah.
Hi, everyone online. Can you hear us? Thumbs up. So Emma gave a thumbs up. So that means they can hear us. And now the room is packed. Standing room only. So let me do a quick welcome. Hi, everyone. Welcome to the weekly noon meeting, the academic meeting of the School of Public Health. This week's meeting is being hosted by the Division of Epidemiology and Biostatistics. And our speaker today is well known to everyone in the room and indeed probably everyone online. Dr. Tammy Phillips is a senior lecturer in the division who's been with us for at least a decade-ish, let's go a decade-ish, and did her MPH and then more recently her PhD in the schools. And her area of expertise within epidemiology revolves around maternal and child health, with particular interest in maternal and child health and HIV, and some of the methodological and let's call it health services and health systems aspects of delivering services and improving the delivery of services to women living with HIV and women more generally, their children and their family. So she's going to be speaking to us today about a project which, in a sense, forms kind of a postdoctoral for you, and a project in an area that she's really provided a huge amount of leadership and spearheaded efforts in the school and the province related to information systems and how we use information systems, not so much to monitor programs, which is often what we think about, but to improve programs in a much more real-time way. So Tammy, we're really looking forward to hearing about your mind study. We'll go for about 30-40 minutes and then go for question and answer, balancing Q&A in what is a packed room with probably 40 people in it and online. Tammy, over to you.
Thank you. Perfect. So hi, everybody. As Landon said, this work is kind of led on from much of my PhD work, and is a project that was funded by the CIFA grant program through the IAS, so just to say that up front. And yeah, focus on the use of routine electronic medical record data to try to improve vertical transmission prevention steps, so infant testing and mothers' continued art after delivery. So what I'm going to do is just talk a bit about the background and some of the work that led up to us thinking about this project, and then the actual REMIND study and the results from the study, and then some of the things that we're still thinking about. So many of you are familiar with this, but for anyone who's not an HIV person, there's obviously been huge progress over the last decade in scale-up of antiretrovirals and provision of antiretrovirals during pregnancy and postpartum. And so this slide just shows the massive reduction in new HIV infections of children over time, down to around 160,000 in 2021 globally. And along with that, just in South Africa, we have, as you know, a really massive population of people living with HIV and on ARVs, about 4.8 million women aged 15 and older. Quite high ART coverage, about 80% among those women, but a really, really high ART coverage in pregnancy. So 98% of women receiving ARVs during their pregnancy, and an estimated vertical transmission of about 3%. And that includes both pregnancy and breastfeeding transmission. These are the stat bars from the UNAs, which help us to dissect a little bit where new HIV infections come from in children in particular. And I just wanted to hone in, I can't see my slides, but it's quite closer, on 2021, where we've got just about 10,000 new HIV infections. And this shows how it's grouped together. The top part of the graph shows transmissions that were attributed to pregnancy and in utero, and the bottom part, transmissions during breastfeeding. And I just wanted to point out now that almost half of the transmissions are occurring in the breastfeeding postnatal period. And a big chunk of those are women newly acquiring HIV during pregnancy, which we've heard about from the PrEP team a lot. And another big chunk is the gray box at the bottom, who are women who started treatment prior to their pregnancy, but drop off of ART postnatally. And then a smaller group of little blue ones at the bottom are women who started treatment either during or after pregnancy, and then had poor adherence or dropped off the path. So a really big chunk of postnatal transmissions. We know that engagement in care in the postnatal period is a problem, and is really key both for the woman's own health, but also obviously for preventing onward transmission of the baby and any sexual partners, but also more broadly for family and societal health. I think we increasingly realize how much a woman's health impacts on the broader her family and community. I was trying to look for more recent reviews, and I don't think that they have been any that I'm aware of, but there was a 2018 review of studies in Africa, only including women who initiated treatment in pregnancy, that found only about 73% of women were retained 6 months after ART initiation in pregnancy. And in terms of EID, about 39% of infants not receiving complete infant diagnosis through to 18 months postpartum, with the bulk of the loss happening in the first 6 months. And we see that in women as well, a lot of loss happening in the first 6 months after delivery, similarly for the babies. Some data from closer to home with Khayelitsha, data from Orly Nelson and Florence, based now with the PhD team. About 77% of PCRs done at 6 to 10 weeks. Only 58% of repeat tests done at 10 weeks from Florence's data. And from some of the work that I've been doing with IDEA, we're finding 26% of women are disengaged by a year postpartum, which is in line also with those existing reviews. And just to point out this sort of changing landscape, as you saw with that gray bar in the spectrum, a big chunk of transmissions coming from women who were already on treatment prior to the pregnancy. And this is really what we're seeing in the services, more and more women presenting for antenatal care already on treatment or treatment experience. From some of the work that I've been doing through my PhD and other work with ICAP and CDC, really pointing out the transition of location of care is a point of loss. This is from a systematic review that we did that tried to describe all the points of transition from a woman living with HIV entering antenatal services for her pregnancy care, and then where did she have to go postnatally for her ongoing HIV treatments and for the baby's care. And we get transitions both into the antenatal care services, which are sometimes integrated antenatal and HIV, and then from that also transitions of location of care to continue postnatal care, which may or may not also be integrated with the mom's HIV services and the baby's care. There's a lot of evidence in the literature that transitions happen and that they're complicated, but there's hardly any evidence around approaches we can use to help people to bridge that transition. Also from the systematic review, really pointing out some of the issues with transition success, some of them personal factors with the participants, fear, knowledge and preparedness. Sometimes it's a complicated process, often structural issues within the clinic, and sort of quite hard formal requirements for transition. I had to have a transfer letter, documentation, understanding of the process, and lack of coordination, I think, between the referring and receiving clinic. And that was highlighted again in some qualitative work that we did in Côte d'Ivoire, Lesotho, and Malawi. So in our more local setting, if we hone in on Gugulethu, which is where I work, there's the Gugulethu Midwife Obstetric Unit, which has a broad catchment area of women presenting for antenatal care across the substructure, and more broadly, we know that women travel in from the Eastern Cape and other places to receive services here. And then after they leave, so they get their integrated antenatal and ART care in the maternity unit. And then after they deliver, after the maternity unit is responsible then for about 10 days postpartum, and then they're transferred on to postpartum care at a primary healthcare clinic in the province. So just this map shows that there's probably 9 or 10 different primary care clinics where a woman could go for her HIV care and the baby's baby care, just within a small radius of the MOU. And that postnatal care may or may not be integrated. So ideally, the mom and baby receive care together at the same clinic, but very often the mom and baby are attending different clinics for various reasons. Some work from my PhD also just highlighted that mobility. So we found that after leaving the MOU, only 77% of women had evidence of being picked up at an HIV clinic in the first 2 years postpartum. So really giving them a lot of time to show up. Obviously, some of them would have been in the Eastern Cape as well. Quite a lot of movement between clinics, and a huge spread of different clinics. So women showed up at 98 different facilities over that 2-year period, which just makes it really difficult to track what's happening for any one woman. So what are the challenges? It's hard to monitor and intervene for all of these reasons. This transition of location of care, geographic mobility, the separation of the mom-baby care. So moms and babies fall through the cracks through this period because we don't really know who they belong to and who's responsible for the follow-up. How do we know that they're actually missing? So then I came across this data to care idea, which is a CDC endorsed intervention that's used quite widely in the US and in other high income contexts. Where they use routinely available HIV surveillance data to identify people with gaps in HIV services and to facilitate linkage back to care. And I was like, this is cool. Can't we do that in our setting? And then I discovered the Provincial Health Data Centre. I was like, maybe we can do this in this setting. So the Provincial Health Data Centre, for those of you who are not aware, is this incredible data harmonizing platform, I suppose, for lack of a better word, that pulls together data systems across the province in terms of ART dispensing, laboratory data, visit data from all the data sources, using the unique patient folder number that we use in the province that allows us to link data sources and people across different clinics in the province. So we thought there was an opportunity to use this routine data to more easily track linked mother-baby pairs prospectively, to see all that information in one place, and to rapidly screen out the mother-baby pairs who are actually doing fine and focus our resources on those who required intervention and quite rapidly trace them and relink them back to the services. So through various discussions with colleagues at City and the province and the Provincial Health Data Centre, the Remind study came to and was funded. Thank goodness. So the aim of the Remind study is to use this linked data to actively identify and trace mothers and their infants who had gaps in routine vertical transmission prevention, with really two pieces. The one, to validate the use of the data. How accurate is the routine data? Does it make sense? Are we picking up people who shouldn't be picking up? And then can we trace the moms and babies with true gaps and link them back to the services? So we decided on gaps to include that were points where both the mom and baby, a mom living with HIV should definitely have these steps, and an HIV exposed baby should definitely have these steps. So we included birth, PCR and maternal viral load, PCR at 10 weeks, PCR at 6 months, which all babies should have. And then in terms of viral load, all moms should have a viral load at delivery. And per the guidelines, all moms should have a viral load at 6 months postpartum. So not including any consideration of breastfeeding status or anything like that, because we just don't have those data, the routine data systems. Then we added in whether the mom had actually linked to HIV services after delivery, because that was a key thing from the work that we'd already done. So they usually get dispensed about 2 months of drugs at delivery. So about 3 months post-delivery, a woman should have presented at her next clinic. And then looking for further gaps in care. If a mom had a gap of more than 90 days without getting dispensed off, that would have also been a flag for us. So what did we do? We enrolled women living with HIV at the Double-Elected MOU. Adult women 18 and older, either late in their pregnancy or early postpartum, really just to maximize the postpartum follow-up time in a relatively short grant. We had 2 years of funding. They did one interview administered questionnaire at enrollment. Here you can see Yolanda and Portia sitting in our study office. And then after that, face-to-face contact, everything else was done through the routine data and through telephonic contact. So we assessed gaps in the single patient viewer in the PHDC center. So you put the patient's folder number in and you can see where they've accessed care, and then using existing maternity cascade and HIV cascade reports. And we checked those for women who consented to be in the study roughly every 2 to 4 weeks to pick up the gaps that we looked for. And then we tried to validate the gaps in the source data. That ended up being quite complicated, and the biggest point of validation was really the track data to see if somebody actually had a lab test on the track system and whether that showed up in the PHDC data. And then Portia, we had a research employed community health worker who then contacted women to further understand reasons for the gap, what was happening, where are you, and try to link them back to care. So we enrolled 336 women in 2021 and 2022. Average age was 32, so really quite a small group of younger women, unfortunately, because I think that's a really important group, and we know that younger women are more at risk, so it is a slightly older cohort. So lower income group, 78% unplanned pregnancy, which is what we see generally in this setting. And again, just to flag this really changing landscape around ART treatment, 85% of the cohort were ART experienced, median of 6 years already on treatment, but 40% of women reported that they'd interrupted treatment at some point prior to the pregnancy. So this sort of cycling in and out of care going on, which is important to notice. So the validation data, what you can see here in the graph along the x-axis is the different gaps in the birth PCR, whether the mom had ART at delivery, 10-week PCR, whether the mom had linked to treatment by 12 weeks postpartum, the 6 months PCR, and whether the mother had a later gap in ART. I haven't included the 6-month viral load. I'll talk more about the 6-month postpartum viral load. And essentially what we saw is that about 40%, 38% of mother-infant pairs completed their care through we only followed up through 9 months postpartum, and they completed that without any gap. They were all good, about 40% of them. And the remainder had possible gaps identified in the routine data. 31% of those were data errors within the Western Cape. So it turned out the woman or the baby was in the Western Cape and had access care. The PCR result, for instance, was there available in track, but I couldn't see it in the routine data for some reason. 14% were women who reported being in care outside of the Western Cape, so we wouldn't have been able to see that because we don't access those data. And 27% were confirmed gaps, a bunch of them in the Western Cape, 17% and 9% outside of the Western Cape. And then there were 28%, which was a big group who we counted as presumed gaps. There was no other evidence to suggest that they'd access care, and we were unable to contact the woman, and so we don't know any better. So we counted that as presumed gaps. It's the data errors that are problematic in the context of this sort of intervention, because ideally what we're trying to do is get rid of those people so that we can really focus in on the people who have true gaps, and I'll talk more about that. Moving forward, also, for the purpose of the study was really to think about gaps after that transition out of the MOU setting. So I'm not so much going to talk about the birth things because most of that's picked up in the services really well. I'll talk now about where the data gaps came from, but it wasn't really the primary focus. I'm going to focus on the 10 weeks onwards part. So where did the gaps come from? Obviously, there's this chunk of people who are outside of the province. We can't access the data. We just don't know about them. And then the biggest issue was laboratory test data that was actually available but wasn't pulling into the PHDC. So through engagements with the PHDC, we see through a bunch of examples. This was also picked up at the time through other people working with the data. And an import fix was implemented in February 2022, so close to the end of our study enrollment. So essentially, there was an issue in the way the data was being pulled into the PHDC from NHLS. That has been fixed, and so we found that just in the instance of birth PCRs, as an example, dropped from 18% data gaps to 1% after that fix was implemented. So really shows the value of the use of the data and these feedback loops. Obviously, there's a bunch of other work ongoing in the PHDC to strengthen the data, but a bunch of those issues have been resolved, and there's ongoing work around that. There were very, very few issues with ART dispensing data. We were initially validating by cross-checking with a premise, which is the city data, because that also all pulls into the PHDC. But after the first few checks, realized that all the city data was pulling through. We didn't pick up any gaps, so stopped with that process. So sometimes they are occasionally capturing errors, or it's just sort of difficult to figure out, but very few issues with that, and moms aren't. And then some issues with folder numbers and linkage. So people still end up with multiple folder numbers. Often those are linked together in the SPV. So when you search a patient's folder number, it will come up with all the data that's attached to any linked folder number for that person. But it's not always that the mom and baby are linked immediately at birth, even though they're supposed to be. Almost all moms and babies were linked by 12 weeks postpartum, so that got better over time. So particularly the birth sort of PCRs and stuff were sometimes a bit tricky to figure out. And there were a few instances where the mom's data or the baby's data was captured on the other person's folder number. So the baby's PCR was under the mom, or the mom's viral load was captured under the baby. So that got a bit confusing, but it was very, very rare. So to focus on what we consider the probable gap. So again, I'm just looking at the 10 weeks onwards, 10-week PCR. Did the mom link to care? Did the baby have a 6-month PCR? And did the mom, after she'd linked to care, have a subsequent gap? So there were 95 that were confirmed gaps, and 85 that we just had no other evidence. So we counted them as presumed gaps. So if we count all of those together, that means 40% of mother-baby pairs had a gap in the time period. If you just counted the confirmed, it's about 20%. And where did they come from? So 16% of women didn't link to care after delivery, and 13% of women who linked subsequently had a gap later postpartum. 10% of babies didn't have a 10-week PCR, and 17% of babies didn't have a 6-month PCR. It was really difficult to contact people. We only had contact success in about 50% of cases, trying to get the mom on the phone and figure out what was going on. And then of those, only just under half, we actually managed to successfully close the gap and make sure that the mom and the baby got back into the services, which is not great. There were lots of, not everybody provided consistent reasons for the gaps, but among those who did, lots of issues around mobility coming up, mobility both in the Eastern Cape and more locally, lots of issues with transfer letters, and like both like women saying like I didn't go because I was late and I didn't have the transfer letter and I didn't think that they would accept me, so I just didn't go. And other times where women did go to somewhere, but she didn't have a transfer letter and she was turned away. So issues on both sides around documentation, some issues around employment, definitely issues around fear of being scolded, stigma. Those were sort of the main things, but the sort of mobility transfer letter stuff came up over and over again. I think the tracing outcomes, just to say here, this aligns with the existing literature around success of tracing. We only did telephonic tracing. We had intended to do home visits, but the study started during COVID and had various pauses, and so we didn't do face-to-face contact. And then we continued just with telephonic contact, and the literature generally suggests that a face-to-face contact is probably more useful for this sort of tracing, and that some more intensive intervention, I think, is needed at that level of engaging with the woman, problem solving, understanding her barriers, but actually getting to her and finding her is difficult. And we know even with the community-based services, and like I think it's all women are supposed to get a home visit at some point in the postnatal period, and a lot of women don't consent to that. They don't want somebody coming to their home. So there's other challenges around that. We've started looking at factors associated with any probable gap, and not unexpectedly younger age, women under the age of 25 were more likely to have a probable gap. And then this art history comes up again. So compared to women who were arts experienced that didn't report any treatment interruption, women who reported a treatment interruption prior to the pregnancy were 2 times as likely to have a probable gap, and the results were consistent when we limited that to just confirmed gaps. The risk ratio went up to 2.45 if we just looked at confirmed gaps. Some other complexity that came up, as expected, the cohort spread to many different clinics. So this is really a strength of using this linked routine data. At the 10-week PCR, babies were at 24 different clinics within the province. Moms were at 34 different clinics in the Western Cape when they're linked to HIV care postpartum. And 13% of the mother-baby pairs reported being outside of the province at some point during the study. This is among the women that we had contact with. Care is often not integrated, so even though our policies are for integrated mom-baby care, often that isn't the case for various reasons, and we're still busy with qualitative work trying to understand some of this. So of the 63% of moms who had both a 10-week PCR and linked to care in the Western Cape postpartum, 41% of them, the moms and babies, were attending different facilities, which is quite a lot. So to figure out why, because all of these services are offered at one facility. And then there's some missed opportunities. So I've been interested in whether there was an overlap in the mom's gaps and the baby's gaps. So this is just at the 10-week time point, and the orange boxes are really the missed opportunities. So there are 43 babies who had a 10-week PCR, but the mom did not link to treatment postpartum, and there were 14 moms who did link to care postpartum, but the baby missed the 10 PCR. So that means the services are not talking to each other, not considering both the mom and baby, in particular if the mom and baby are not in the same place. So just to go back to the 6-month viral load, which I sort of overlooked because it is in the guidelines that every mom living with HIV should have a viral load at 6 months postpartum. We stopped actually validating that because we realized, and we stopped phoning women for this gap because we just realized it was just being very poorly implemented in the services. And I think the main reason for that we fed it back into the services, so it's part of conversations in that space. But I think the issue is that a woman who is postpartum, once she's gone back into routine HIV care and she's back into her adherence club or wherever she's accessing her routine services, is not considered postpartum. She's not considered different to anybody else. So implementing a guideline that requires a viral load at a time point outside of sync of everything else is just very complicated. So I think we need to rethink that. I think of interest, so in this case it was only 38% of the moms who were actually attending HIV care and had art in hand around 6 months that had a viral load done at that time. And 20% of those were above 50 copies, 7% above 1,000 copies. So there is some viremia in that group and lots of women not having that viral load. Again, unfortunately, we don't have breastfeeding data, so we don't know about infant. Just talk about the transmissions, again, with the caveat that this is through the 6-month PCR, so this is not full breastfeeding transmission. There were 5 transmissions during the study. 4 of them could be bundled into the in utero intrapartum space, 1 PCR positive, 3 positive at 10 weeks, and then 1 that was most likely a breastfeeding transmission where the baby was negative at birth and positive at 6 months. The in utero ones is a bit beyond the scope of the study because we didn't follow women right through their pregnancies, but they were mostly coming in with a high viral load or had evidence of a gap in treatment during their pregnancy or a high viral load at some point during their pregnancy. And then the breastfeeding transmission did not continue after postpartum. And it was a mom that we did not manage to contact. So some complications there. Also quite a lot of indeterminate test results. And I should actually go back and check in terms of the whole cohort around indeterminate tests. And some people have flagged perhaps issues around an early infant diagnosis in the context of dolutegravir and sort of what that means for our early infant diagnosis. That's not my area of expertise at all, but it's something perhaps to think about. So some take homes from Remind. I think using the linked electronic medical record was really valuable in this context of wide geographic spread and where people have to physically move their services. It's like a no-brainer that we have access to this data system that allows us to look at people regardless of where they're accessing care. Not being able to access data outside of the province is obviously a limitation. It's not here, but sort of ongoing work is required to strengthen the routine data, although that even through the course of the study improved massively. At least 22% of mother-baby pairs had a confirmed gap, 40% if we count those unconfirmed probable gaps. So it's quite a lot in this quite short time frame through 9 months postpartum. Younger women were more at risk, which we knew, and I think we need more attention around this art history coming in, because I think pregnancy is this really cool opportunity, although overwhelming time for women, to really say, okay, what's happened with your treatment experience up to now? Either you're restarting here in the pregnancy or you've had interruptions before, what worked, what didn't work. We have an opportunity to engage them. And I think one of the key lessons from this study is that knowing who has a gap is really not sufficient, because that point of contact is really the key. How do you get to the next step? We only managed to contact 50% of women, and of those, only 50% we managed to link back into the services. Lots of issues around trust, both from the patient to the provider and from the provider to the patient, I think. So I think we have work to do there. Contact information is really, really challenging, even in the context of a research study where we had, captured additional contact information and alternative contacts. And then we didn't do such a great job of connecting with the community-based services for home visits. We did meet with them before the study, and then given that this was really pilot proof of concept with a focus on the data validation, decided to do a research employed community health worker for the telephone calls and tracing. But I think a next step would be definitely to embed that into the existing referral and like home visits systems that already exist. So looking forward a bit, they've just National Department of Health has just released new guidelines for vertical prevention transmission that has these great tables around integrated care for the mom and baby, both for women living with HIV and for HIV negative women, thinking about ongoing testing and prevention. But I did just want to flag, I think this handover from the neonatal period, those 10 days where the mom and baby are the responsibility of the MOU to the primary care clinics, that handover process is still a bit problematic. The receiving clinic ultimately doesn't know that the mom is coming until she comes, and the MOU has provided a transfer letter, and so it's no longer responsible. So if the mother doesn't show up for her baby care or for her ongoing art, like who is supposed to call her? I don't think we know at the moment. And then I think from this study, you see that even in a context where integration is highly valued and we're trying to push for integrated services, often moms and babies are attending care separately. So how do we make sure moms and babies get all of the services that they require, even if they're not in the same place and then nobody falls through the cracks? Also in the new national guidelines, is this phrasing around like you cannot turn somebody away from the facility if they don't have a transfer letter, you have to provide treatment. There's been policies around this in the Western Cape for a long time, and clearly this is still difficult to do. So I think there's work needed around sensitizing providers around this, but also patients' empowerment and education. So what can a patient do if they do get turned away from a facility? What are there ways that we can think about how to preempt transfers, make sure people have a proof of treatment on them? I think those are things to think about. And in terms of some next steps, so we're still busy with an implementation evaluation of the Remind intervention. That's Yolanda's PhD. So she's been doing in-depth interviews with patients and providers and policymakers to try to unpack some of these implementation issues and how this might actually work in practice now that we have some of this data. Brian Leonard is an MPH student who's been looking at art history prior to pregnancy and viral load at delivery and linkage to care. And he's finding similar to this is that the women who have history of treatment interruptions are more likely to have a high viral load at delivery, less likely to link to care postpartum. And that work links to my K43 grant, which is looking at developing an intervention to support people who return to the services after a treatment interruption. So that's ongoing. And then having lots of thoughts, and Aurelie Nelson and I have been chatting because she's thinking about this from the HIV negative mom's perspective, but thinking about ways to strengthen the handover between delivery and primary care clinics, thinking about where an intervention like this would sit. You know, it's again like who's responsible. Is this something that might sit, like who would look at the list if we were to create an action list in the PHDC? Like who would actually be responsible for that, given that there's such a spread of women geographically, like who takes responsibility? There's, I think, need to increase access further to the SPB and the PHDC systems within the clinics. And I know that work is ongoing within the PHDC, but there's a lot of infrastructure issues there. I know the nurses and goods are often sort of looking up blood results and track on their phones. They don't have access to a computer. There isn't Wi-Fi. So how can we better use this system that is available? Like I said, better links to community-based services, and really thinking about this issue of trust between patients and providers. It's crazy that this far along in the epidemic, these issues of stigma, fear, mistrust are really pervasive problems that require more attention. And then thinking about this mobility issue as well. I keep coming back to this transfer. Like there must be a way that we can provide people with a proof of transfer or proof of care almost prophylactically. Like every woman gets a letter that says wherever you go, this is what your history is. Like how do we do that in a way that can really help that? Because it's definitely not just a out of province problem. I know there are issues in terms of women accessing care in the Eastern Cape and resources available and all sorts of things like that. But within the Western Cape, which definitely should not be the case that a woman gets turned away without a transfer letter, particularly because they can actually just look up possible to just look up and see where the woman was and what her history was. So yeah, that is what I have for you. Gonna go next, but it won't go next. Yeah, just some acknowledgements. Obviously, the moms and babies who took part in the study, the health service staff have been really, really helpful. And I'm really looking forward also to seeing the results of Yolanda's work, where we got more feedback and insights from the health service staff. The Provincial Health Data Centre team, really phenomenal and has been incredibly patient with us. Our site team and obviously the funders of this work. Thank you very much.
That's great. Tammy, thank you very much. That was sort of insightful and cross-cutting and expert and wonderful. We have about 15, let's say 20 minutes for maximum for questions and answers. We will balance Q&A or questions from the room and online. Tammy, I'm your expert in this. You can manage this yourself if you want. I can manage the online, however you want to do it.
I don't know.
Okay.
If someone could maybe see if there's anything from the.
Great. So I'll sit over here, look at the chat, and we'll manage the room at the same time. Great. So we always give first choice in questions and priority in questions to people who showed up in the room. So we have a first question from Matilda, and Tammy, hold on.
Hi, I'm just curious if a digital platform like OnConnect and help with strengthening and I know the postpartum, reminding patients to go through follow-ups.
Yeah, absolutely. So those kind of like push reminders, definitely. I don't know, because they happen kind of already, right?
Yeah, I don't know if it extends like postpartum, but
it does. I think it extends postpartum. I'm actually not sure. I also know through MomConnect there's access to like a hotline, and I know the Western Cape Department of Health also has a hotline in it, but I'm not sure that patients really access it, because you think like, so what is it that makes somebody feel empowered enough to say, I don't know where to go, who do I phone, who do I talk to? I think that is part of the problem. But if we could message it in something like that that's already existing, like if you're having, like you need to access care at this time, if you're struggling, phone this number or talk to this person, that would definitely be helpful.
Good. We have a question online from Virginia.
Hi, thanks so much for a great presentation. I wanted to ask you, from what I gathered is that you found the people to include in your study through going through the data center set of women who are likely to have defaulted treatment or not connected with their babies. Now, nowadays with Poppy, we can't really do that form of recruitment off her database that's really there for patient care. I understand that it wasn't a consented database at the beginning. So how would you recommend we do this moving forward? The research is really valuable, and I don't know if you've got any ideas about how we would do that moving forward. I mean, we could offer a service and it could be done as part of patient care, but for research, I'm not sure. Thanks.
Yeah, I totally agree, Virginia. So this was a consenting cohort. And I only, in the SBB, I only had access to the women who consented to be in the cohort. So I submitted a list of enrolled participants that got added to a list that so I wasn't able to just search for anybody in the SPV. But I think that's a really good point in terms of, so the idea with this project was really to be a stepping stone between sort of understanding how it would work and the sort of the data validation side, and then like would it be possible to implement in the services? I think your issues around the like Poppy and stuff are going to come up in many places, and I'd be interested for those in the services, sort of how that's being dealt with. Because I totally agree, this shouldn't be a research specific activity. Right. This was a consenting cohort who knew that I was accessing the data for this purpose. And then only the gaps were searched for in that cohort. So we recruited face-to-face in the MOU. But But moving forward, in terms of home visits, telephone calls, people updating their contact information, they absolutely need to know what that information could be being used for. And within the services already, the community-based services and the home visits that are intended to happen postnatally and during pregnancy, I think women have to opt into that and consent to that process. And I think quite a lot of women don't consent to that process, but I'm not 100% sure. But I totally take your point, Virginia.
Good. Thanks, Virginia, for the question, and Tammy for the response. Other questions from the floor, Natasha?
How would you deal with patients that come as duplicate patients in the data set, prevention health data set, with different patient IDs? Because I've seen that happen before, and so, how do you manage that?
So the data center manages that. So
Okay, so then they would.
no, so there's a huge amount of work in the back end of the PHTC around linking and harmonizing people and deciding who are the same people and who are not the same people with a certain amount of confidence, and whether we can say that we are very sure that this person who has a different folder number but the same date of birth and address and whatever is the same person, and then they get a dominant ID and like with all those folders linked to it. But sometimes people it's not always very clear. But that's a process that happens within the routine data. And I think with these things also, and I know this, like if you go into the SPD, it pops up a thing about this is all routine data, and the onus is on you to also figure out if you think this is real, if you have any flags of an error, because it's pulling in routine data sources, which we know have various errors in for various reasons, and it's doing an incredible job of pulling all those pieces together. But ultimately, whoever's engaging with it, looking at it, needs to also think about okay, does this make sense? Yeah, that answers your question.
Thanks, Natasha. We have two questions online right now. First, we have Lucia, and then Bundley, I see that you typed something and we'll get to that second. Lucia, please go ahead.
Hi, Tammy. Thank you. That's really, really lovely to see this all coming together and see it all in one piece. You mentioned the idea of empowerment a couple of times, and I was interested to know what you think that could potentially look like. And I know I'm asking you to kind of look into the future, but what are your ideas around that, and what that could look like to enable better ongoing engagement, but also some of those issues that you've been talking around about transfer, for example?
Yeah, I think it's something that I've been thinking about a lot in some of the work I've been doing around my K, where I'm thinking of how can we include patient preferences and patient choice into our design of interventions, and thinking about how we offer care. And then how do you balance that within a constrained health service that doesn't really, where it's hard to do proper patient-centered, individualized care. We can't do everything that patients prefer necessarily, because we have to provide care for a lot of people in a short space of time with limited resources. But I do think there's something about are there ways that we can improve patients' ownership of their own health? The woman, and this comes up a lot in our qualitative work, I'm sure for others as well, where people say, you interview people and they're like, this is my responsibility, it's my health. If I need to decide, why did you decide to come back to the clinic? I had just made a decision, it's my life, that's my health, I need to go. And how do you increase motivation and patient empowerment and ownership, so that somebody feels able to make that step and feels able to reroute if they meet with a barrier, because the barriers are quite difficult to remove in entirety. So yeah, I don't know if that answers your question. I don't have an answer really, but definitely something I'm starting to think about a bit more.
No, that's great. Thanks, Tammy. And I know you're already thinking about it. And I think it's also a balance between kind of information and putting the responsibility on the patient, and then also thinking about ways to facilitate it, which I know you're also trying to do from the perspective of the providers and the service. But yeah, that's great. Thank you.
Okay, our next question is from Gundley. Gundley, you're welcome to unmute and ask it, or I can read out your question, and then we'll go to Gavin. Go ahead, Gundley. We see you're unmuted, but we can't hear you, so I'm just going to read. And imagine my voice is that of Gundley. Great work, Tammy. The mobility within and between provinces and difficulty with tracking mother-infant pairs through telephone calls is an issue we see in many cohorts. Do you perhaps have any thoughts on how to tackle these issues?
Have many thoughts, and most of them are might not be very useful. It's really, really hard. I think within the province, it's perhaps easier. I think there are opportunities to further leverage like this sort of like the PhD system that already exists. You know, if somebody moves to another clinic, and I know there are many barriers, and I speak from a naive, like not being a service person perspective. But in my mind, I'm like, do we really care whether a mom accesses her art at XYZ clinic or another clinic or another clinic? Like, can't she show up wherever she wants and get her treatment? And shouldn't we make that as easy as possible for her? And I understand that that's naive and not possible in exactly that way for many reasons. But really being a bit more flexible and making it easier for people to move between clinics and making it easier for the providers to provide continuity of care and quality care in those instances where that movement happens. Outside of the province, I think it's more complicated because it's, you know, there are so many barriers. There is some work around sort of like a patient held record, digital record. All of that would require buy-in, so that like if you did show up at a clinic in the Eastern Cape with your card or your app or whatever it is, that facility knew what that was and trusted it and agreed with it. You know, oftentimes it comes out really that the reason a link has happened is because a nurse took the initiative to phone the other facility and check and go ahead, but not everybody does that. So how can you make this as easy as possible? And I think that speaks back to Lucia's point as well around empowerment. Like if we can be flexible and make that as sort of streamlined and easy, as least complicated as possible, then perhaps it will be easier for patients to navigate on their own. Not sure. I'd be interested to hear what other people.
Interesting. While we think about that, we have one question in the room, and then we'll go to Gavin. Please go ahead.
Transition during breastfeeding. Is that the rate transition you'd expect? When they're supposed to be breastfeeding, do you think people are still having mixed feed and support? Why is there still transmission during breastfeeding? And so a lot of the study doesn't capture breastfeeding transmission because we don't follow people for long enough. And a lot of the transmission in breastfeeding is new HIV infections. Probably half of the transmissions in the breastfeeding period are new HIV infections, and then the rest. I think probably it's an adherence retention related issue, you know, and people don't necessarily. People have. There's some literature that like there's a negative test and then there's a false sense of security and you continue and life gets crazy. And I think also people breastfeed intermittently, so they might consider themselves not to be breastfeeding, but still occasionally the baby's on the breast at some point. So I think there's various things that are going on, but the vast majority of it is infection.
Thanks for that question. We'll probably take Gavin's question and then we might have time for one more. Gavin, go ahead. If you want to unmute.
Thanks a lot. And thanks for your excellent presentation. But now I'm feeling a bit pessimistic now. So it's long been a suggestion or recommendation or been pushing that the services should use SPV to find people who drop out of care, whether it's for HIV, diabetes, etc. So anyone in chronic care. And there's always been the assumption that you would get great returns on this. However, in a sense, almost in the best case possible, because here you have patients who prospectively agreed to be followed up, plus you have a dedicated research team following them up. The actual numbers that you could bring back into care were relatively low. And of course, there's no guarantee that they won't drop out again. In fact, it's highly likely that they will drop out again later on within a few months or a year or so. So the question is, what would you recommend to the services? Should we actually be putting effort in trying to do this, using our electronic tools to find those who dropped out of care and try and return them to care? Or is this an activity that might utilize staff time less efficiently than we imagine?
It's a great question, Gavin. Thank you for that. And yeah, I've been having similar thoughts. So I think particularly in the context of this period of risk of transmission and high risk of loss from care, I think there is potential value. But I think what I've realized from this work and is reflected in other work is that having the routine data and that list of people, which would have to, I think, be more targeted than what we were looking for, is only a piece of the story. And what the actual face-to-face intervention is on the other end of that is really critical, because otherwise you don't get the return on investment of the time of the phone calls. So there are probably layers where there's sort of low, like, I wonder if there are easy ways to improve our contact information or encourage patients to improve their contact information. Although that again goes back to a sort of trust in the health service and who wants to provide their real contact information and all of those things. So that there are perhaps other areas of investment. But I think we also need to know more about what do you need to do when you get that person on the phone or when you get that person in front of you to help them link to care. All the ongoing research that's showing people cycling in and out of care, this is just, I think, something we have to become a little bit more comfortable with because it's happening all the time. And so how do we make it easier for people to reintegrate back into the services when they choose to? Because a lot of people delay return. Even in this relatively short cohort, women said, I didn't go back to the clinic because I was afraid. I was already late for my appointment. I didn't have a transfer letter. I wanted to go to a different clinic. I didn't know how to navigate that. I was afraid of how I would be treated. So I didn't go. So I think the one thing that comes to mind is how do we make it as inviting, as accessible as possible for people to come back when they're ready to come back? With the caveat that perhaps in situations like vertical transmission prevention in and around pregnancy and an early time postpartum, perhaps there's value in a bit more of a resource intensive activity around that period. Yeah, I don't know. Also interested to know what other people think about that.
So it sounds like based on Gavin's question, Tammy, you're saying that this is part of the puzzle, but this on its own is not going to solve this very complex, but it can be a tool that can enable new possibilities for intervention.
And I think that the value of the data center, which is probably, like you say, Gavin, people keep coming back to it, is it allows us to pick out the other 60% of people who are fine. They don't need a phone call. It doesn't matter what clinic they're at. They're doing fine. They're getting their things. We don't have to phone them. Whereas with our views, with using just facility-based lists and things, it's very difficult to know that because people are clearly presenting for care all over the show.
But yeah, with new technologies come new opportunities, come new questions. Yeah, absolutely. Wonderful. Now, colleagues, I think that's, I know we're at 1 o'clock and people are starting to filter out. So that's all the time we're going to have. Lastly, please can we say a huge thank you online? You can clap in the silence of your offices and in this room. Please let's give a round of applause to Tammy on a wonderful. Wonderful, wonderful. Thanks everyone, and thank you, Tammy, for stimulating, enlightening, state-of-the-art and cutting-edge work that, like all of the best work, raises as many questions as it does provide answers. Yeah, so we're a strong report. So thank you again, and thanks to everyone online. Tammy. Really good.